But now to introduce Peter Orszag, just so you know, I've known Peter for more than a decade and been a huge admirer of his work for a long time. Today, honestly, was a really terrific day for SIEPR because Peter spent much of the day in back-to-back meetings. We worked him pretty hard with about a dozen of our SIEPR faculty. He, I think, enjoyed the chance to get a sense of the policy-relevant research that was happening here, and I think for all of them it was useful to get some feedback on their work and its policy relevance, and sort of what are some big important questions that are out there. And at SIEPR, we really aim to connect people like Peter who are on the front lines of policy and business with our scholars. Also here at SIEPR, we have lots of students here in the audience today, undergraduates from health economics and health policy courses, and graduate students who are doing research in this area. So we really aim to bring in people who are going to connect with our faculty here. But now to Peter. Peter really doesn't need any introduction. If I were to try to go through his entire CV, I would take up the entire hour, so I will certainly not do that. He's currently the Vice Chair of Corporate and Investment Banking at Citigroup, and he's also the Chairman of Financial Strategy and Solutions Group there. Prior to that, he's done many things, but one quite noteworthy thing is that he was the Director of Office of Management and Budget in the Obama administration, and before that, directed the Congressional Budget Office from mid-2007 through the end of 2008. He's done a number of things before that. He served on the Council of Economic Advisors. He directed the Hamilton Project at the Brookings Institution and was Deputy Director for their Economic Studies program. And much of his focus in his research over the years and in his work has been similar actually to mine and to many people who are involved here at SIEPR, which is thinking about the budget impact of rising expenditures on healthcare. Now 18% of GDP, over $3 trillion likely to be in 2015, and obviously a big issue here at Stanford locally and in the Bay Area more generally. So it is, and Peter probably understands better than just about anyone on the planet the difficult trade-offs that we face in thinking about as we spend more on medical care. What do we get for that, and how do we manage the economic impact on things like wages and employment? So please join me in welcoming Peter Orszag, who's going to tell us now about the evolving healthcare landscape.
Thank you very much, Mark. I'm delighted to be back at SIEPR and back at Stanford. Also, thank you all for coming, including President Hennessy and President Levin. I just picked up on the fact that there's a university president garb that involves khaki pants, striped blue shirt, and blue blazer, for those of you who are aspiring to such a position. Wanted to talk with you about the healthcare landscape, and in particular, what's been happening over the past 5 to 10 years, and then some discussion of what the future might look like. So let's just jump right in. For those who might want to fall asleep in 5 or 10 minutes, I'm going to give you the Cliff Notes version of what I'm going to say. So first is that if you wanted one indicator in the current environment of the underlying utilization trend in healthcare, I would look to Medicare spending, especially Medicare spending per beneficiary. And the reason is that total healthcare spending and employer-sponsored insurance spend have a big business cycle component to them. And they also are having, in the midst of a significant coverage expansion. Medicare doesn't have either of those features. Coverage is rising gradually, and it is not cyclical. So if you're looking for a pure underlying indicator of what's happening in the health sector, at least for right now, Medicare is a good place to look. Second, interesting research over the past few years has pointed to post-acute care, that is, what happens after you leave the hospital, as both being the source of most of the variation across the United States in Medicare spending at least, and also potentially where we waste the most money. That is where there's the deepest negative correlation between how much you spend and any measure of quality, suggesting that perhaps there should be renewed emphasis on that particular part of the healthcare system. Third, we're in the midst of evolution away from fee-for-service payment towards fee-for-value payment, but we need much more specificity about exactly how that is going to happen. And I'm going to talk a little bit about the way I think it will progress over the next year to two. Fourth, we obviously are in the midst of a hugely politically polarized environment, so the question becomes what happens in that environment, and I think the answer is nothing much. In today's environment, as I'll show you, unless one party or the other controls the White House, the House, and the Senate, you should not expect any big changes, and that includes if a Republican president wins a Republican nominee wins in 2016, but the Senate flips back to being Democratic, all the talk about big changes is unlikely to be the reality. And then finally, just end on a recent National Academy of Sciences panel that I co-chaired on the increasing gap in life expectancy, which actually ties in quite nicely with the new Angus Deaton and Ann Case analysis that has gotten a lot of press attention, showing a dramatic change in the pattern of life expectancy by education and income. All in 30 minutes, and then we'll talk, I'll take some questions, which by the way can be about anything, not just about what I'm discussing. So if I start to pick up the pace here, it's only because Mark has limited my time. So first, in terms of the underlying trends, we have experienced a fairly substantial deceleration in healthcare costs over the past several years. You can see that here that it's been across the board in private insurance, in Medicare, and in Medicaid. But the underlying drivers of that deceleration are likely quite different in the different parts of the healthcare system. And in particular, the big question is how much of this slowdown was cyclical, because we've gone through the great financial crisis and slow growth afterwards, and how much is structural, that is, doesn't have to do with the business cycle and therefore maybe might persist for a longer period of time. I'll immediately say that there's been a bunch of analyses done that try to answer that question in a not particularly informative way. What they do is they take total healthcare spending and regress that on 20 or 30 years of data on unemployment this year and the previous 6 years or so, and they get wildly differing shares of the slowdown that's due to the economy as opposed to something else. That's not very informative because you don't have that many data points, and the results are very sensitive to whether you start in a particular year, whether you include 6 lags of unemployment or 7, and I can get that share to move from approximately minus 50 to plus 200%, depending on the way I do the analysis. So instead of doing that, I think a more informative perspective has been adopted in a couple studies where you look across the United States and ask the simple question, are the places that were hit harder by the economic downturn where healthcare costs slowed the most or not? In employer-sponsored insurance, you see a very significant relationship. This graph shows you that the localities where the employment to population ratio, that is the share of people with a job, fell the most were also the ones where you experienced the slowest growth in employer-sponsored insurance. If you take that relationship, there's a little bit of statistical leap of faith here, but if you take that relationship and then ask, let's use what's happened to the national employment to population ratio, so the share of the country as a whole that had a job and how that changed, take that relationship and ask what would happen to healthcare spending, you get this answer, which is the top blue line, the projected spending growth for employer-sponsored insurance, had it not been for the recession, basically. And what you can see there is that doesn't move that much, unlike the red line, which declined. The spending growth abstracting from the recession is basically flat, which is to say you can basically explain effectively all of the slowdown in healthcare spending in employer-sponsored insurance because of the economic downturn. So that raises the obvious question, well, hold on a second. I thought out-of-pocket expenses were exploding and deductibles are going up and all of these changes to the structure of employer-sponsored insurance, that has to be having some effect on spending, but if you can explain all of the slowdown based on the economy, then what happened to the other stuff? And it turns out that there may be less to the out-of-pocket story than you read about in the newspaper. It is true that deductibles are going up relative to total spend or relative to income, but it's also true that 7 or 8 years ago, something like 20% of workers with single coverage from their employers had no out-of-pocket limit at all. Today, that's effectively zero. Healthcare costs are really highly concentrated among a very small share of beneficiaries. If you take Medicare beneficiaries, for example, and rank them by their cost, the top 25% of beneficiaries account for 85% of total spend. So the out-of-pocket limit for many workers is going to be, or in terms of total spend, is going to wind up mattering at least as much as the deductible, even though for most people, the deductible matters more. So let's look at what's been happening to total out-of-pocket spending in the United States. This is not what you would have thought based on the media. If you look at national health expenditures and just take total out-of-pocket expenses divided by total national health expenditures, that doesn't look like it's increasing to me. Now, part of that is a coverage mix. People are moving onto public insurance. People are being covered at all, which reduces out-of-pocket spend. So let's instead look within employer-sponsored insurance itself at that out-of-pocket share. And I should immediately say that if you use a different data source, you get a slightly upward tilt. With this data source, you get a slightly downward tilt, but you're not getting massive increases regardless. So one way of reconciling this argument that it can't all be cyclical in employer-sponsored insurance because there's been this explosion in out-of-pocket spending is just to note, actually, it doesn't look like there's been an explosion in out-of-pocket spending, at least relative to total healthcare spending. There has been an ongoing increase relative to income, but not relative to total healthcare spending. What about Medicare? If we did the same analysis for Medicare and we looked across different parts of the United States, you might not be able to do regressions in your head, but I can tell you that's basically got no correlation, no relationship. The states in this case that were hit harder by the recession were not the places where Medicare slowed down more, unlike for employer-sponsored insurance. And by the way, that might make sense. For the majority of Medicare beneficiaries, Social Security is the majority of their income. Social Security is protected against downside risk. For the vast majority of Medicare beneficiaries, there's some form of wraparound insurance, either Medigap or employer-provided retiree insurance. And so their net out-of-pocket expenditures are often quite low. And you might not, therefore, expect any cyclicality to Medicare, which is indeed what we see. And if you do the same kind of analysis that I did before, where we say, well, what would Medicare have looked like but for the recession? The answer is it would have looked pretty much like what happened. So most of the slowdown, in fact, pretty much all of the slowdown, persists even after you control for the state of the economy. Much different picture than with regard to employer-sponsored insurance. These changes have been pretty big. So I can tell you as someone who used to run the Congressional Budget Office, it is not an agency that likes to incorporate incoming information in a very rapid way and then encapsulate that in its projections. It tends to like to move more slowly in response to incoming information. So these are really big changes in a short period of time. If you look at the 2020 share of GDP projected for Medicare and Medicaid, it's fallen by almost 1% of GDP, or something like 15% between August 2010 and March 2015. If you take almost 1% of GDP and accumulate that over 30 or 40 years, and then add interest on top of that, you get a very big change in the projected debt trajectory for the United States. So the dotted line is what the official projections adjusted for the expiration of the tax cuts, which was not a reality at that point, look like as of 2010. And the dark blue line is what the official projections look like today. A completely different picture. Now, I wouldn't put too much weight on these projections because the confidence intervals around them are very, very wide. But the fact of the matter is, most of the editorial boards in the United States have not updated their rhetoric to reflect the current projections as opposed to the projections as of a few years ago. The 2040 debt to GDP ratio has been cut in half, mostly because of this deceleration in healthcare costs that has then been projected forward to some degree. That raises the obvious question, are the projections right that we would expect the slowdown to continue or not? There's been a little bit of a pickup in 2015, which if I updated it for anecdotal evidence from publicly traded firms like the big payers and the big providers more recently, suggests a little bit more tailing off. But in the back half of last year, in terms of total healthcare spend, you can clearly see that things picked up a little bit, especially in prescription drugs. This is a little bit misleading because this is the growth rate in those individual components. Prescription drugs are only 10 to 15% of total healthcare spend, so even when they grow rapidly, the effect on the total growth rate is smaller than you'd suggest. But you can clearly see some upward kick. That is exactly what you'd expect as the economy picks up a little bit and as you add millions of people to insurance coverage, because despite the hopes and dreams of people on the left, the fact of the matter is when you give people insurance, they consume more healthcare, and so you'd expect more utilization as the number of uninsured people declines. So the relevant question in my mind is, abstracting from all of that, what's happening to Medicare? And you can see that Medicare did have some acceleration in 2015. Most of that happened in the beginning of 2015. And towards the back half of 2015, there's been a little bit more of a slowing. So the short answer is we don't really know, although there's nothing in the past year or so in Medicare other than a bump up at the beginning of 2015 to suggest that this pattern of lower growth is over. And we'll come back to what might help perpetuate it in a moment. The natural question to ask, though, is regardless of how long it continues, well, couldn't this be doing a lot of damage? Because after all, healthcare spending has some benefit, and the objective shouldn't just be to cut spending. It has to be to cut spending in a way that doesn't hurt people, and maybe that's impossible. So this brings us to the second point I wanted to make, which is the research over the past few years on the potential for reducing cost growth in healthcare, or reducing costs, without harming people. There's been a long debate over the literature from Dartmouth that shows just dramatic variation across the United States and how much cost per beneficiary there is in Medicare. This is adjusting for prices and adjusting for other things one can adjust for. Some parts of the country just have much higher cost per beneficiary than other parts of the country. Now, the big debate historically about this has been, well, maybe it's just that you're not doing the risk adjustments right, and the people in the higher spending areas of the country are just sicker in some way than the people in the other parts of the country. So a recent study finally did what I thought should have been done a while ago, which is say, why don't we just look at people who move from one part of the country to another and see what happens to them? Because if this variation were based just on the condition of the patient, when someone moved from the red area to the light area, you wouldn't expect the spending on them to change at all. So let's look at what actually happens. The short answer is you see a very big jump, either up or down, depending on which direction you're moving, right around the time that someone moves. And the way to interpret this coefficient is if spending per beneficiary in Florida is $10,000 and in Minnesota it's $5,000, so there's a $5,000 difference. When someone moves from Florida to Minnesota, spending on them falls by $2,500, and when they move from Minnesota to Florida, spending on them increases by $2,500. So unless you think someone who's living in Florida who wakes up one day and says, I feel really healthy, why don't I move to Minnesota? I guess it's possible, but seems unlikely. That's a pretty good indicator that there's a lot of variation that's unwarranted and not actually geared off of the underlying condition of the patient. So now let's dig one layer beneath that. What the Institute of Medicine showed several years ago was that most of this variation is occurring after someone leaves the hospital, in the post-acute space, not in the acute space. So not in the hospital, but after you leave the hospital. And what you can see in that top line there is this red map, in terms of the color variation, would shrink by about 75% in terms of the variation if we eliminated all the variation after you leave the hospital. Whereas if we eliminate all the variation when you're in the hospital, the color variation would only fall by about a quarter. Most of the variation is after you leave the hospital. And what's interesting about that is it ties in nicely to an admittedly preliminary set of results suggesting that's where we waste the most money in the post-acute space. So there's this been very interesting quasi-randomized study based off of ambulance referral regions. So in most cities, most areas, which ambulance will come pick you up if you call 911 depends on pre-drawn lines where they carve out different territories. And so if you think about the line going right down the middle of this room, and you live on one side and you live on the other, and otherwise you look kind of similar, then this is almost quasi-randomized in terms of which ambulance picks you up, and therefore which hospital system you wind up with. So what do we learn from that quasi-randomized evidence? First, which ambulance company picks you up, and therefore which hospital you randomly wind up in, results in dramatically different spending on you. Again, underlying how much is spent, that shouldn't happen if it were all being driven by the patient condition. Second, if you're getting picked, here, note to self, if an ambulance company is picking you up, ask to be taken to the most expensive emergency room in the area if possible, because the evidence suggests that there is a positive return to cost or to spend in the emergency room setting. However, and this is what's interesting, however, when you follow those patients through, so they're admitted to the hospital and then they're discharged from the hospital, it looks like, again, quasi-randomized, it looks like spending post-acute is hugely wasteful, especially on skilled nursing facilities. Going to a very high-cost skilled nursing facility, even after you control for everything you can control for, looks like it does nothing in terms of producing better outcomes. So these things tie together in an interesting way, because if that's where most of the variation is, and that's where the evidence might be suggesting that we should, where a lot of the kind of negative correlation is between cost and quality, suggests a big avenue for improvement in terms of what we get for our healthcare dollars. I'd also note what's interesting about this research is it reestablishes the Dartmouth flat of the curve kind of finding, where extra spending doesn't lead to higher, better quality, but in a more nuanced way depending on what part of the healthcare system you're in. So how do we get to that? And this brings us to the form of payment reform, delivery system reform. The Department of Health and Human Services has now declared goals that we will move away from fee-for-service payment within Medicare and towards what they call fee-for-value or value-based payment, with at least 30% of Medicare payments being of that value-based form by the end of next year. So what I'm going to put forward to you is there are two major ways in which you can move forward in that way. One is by paying for all of the care that's associated with a particular episode. So think of this as someone has a heart attack, they're admitted to the hospital, and then all the care that ensues from that event, including after they're discharged from the hospital for some period of time, gets one fixed payment with a quality adjuster depending on how good the outcomes are. The alternative is called an accountable care organization, in which the hospital assumes, basically in its extreme version, gets $10,000 per person for all the care that that person might need, including how many heart attacks might happen in the population and what have you. An accountable care organization in extreme version effectively makes the hospital or the provider an insurance company, because they're the ones at risk for utilization or intensity. A bundled payment does that in a much smaller way, because they don't face population risk, how many heart attacks they just face how much risk there is or how much cost there is thereafter. So if you ask me how you're going to hit that 30% goal and the 50% thereafter, you're not going to get there just by making things voluntary, which is the way most of these value-based payment systems have been working. The hospital can sign up if it wants to, and so on. You're not going to get enough take-up to get there if you just do things in a voluntary fashion. First thought. Second thought is you can't make an accountable care organization at this point mandatory. You can't force a hospital to effectively become an insurance company. It's too great a leap. So if you put those two things together, what's likely to happen is that we are going to take more and more of these bundles, these episodes, and cascade out on a mandatory basis. This is just how Medicare will pay for things. First, hip and knee surgery, which CMS announced yesterday in 67 different localities within the United States. Starting next April, that is how they're going to pay for hip and knee surgery, period. It's not up to you, the hospital. That's how we're paying. I would suspect that what you're going to see is cascading out of that approach. So for coronary artery bypass grafts, for certain forms of oncology, and so on and so forth, until you're covered a sufficient share of total healthcare spending that at that point you can make the leap to an accountable care organization. And the administration in the next year can do a lot of this through administrative fiat rather than through new legislation, which brings me to the next topic, because new legislation is not going to happen. So let's talk about political polarization. This is your Congress. The dots are individual members of Congress. The upper left might be hard to see, that's the late 1940s, and the bottom right is 2011, if I remember correctly. So the blue dots are Democrats, the red dots are Republicans. How far the dots are apart from one another depends on how frequently the members of Congress vote together. So what's interesting is if you look up in the late 40s, you can see there's a Democratic Party and a Republican Party, but there are a bunch of Democrats that are actually closer to other Republicans than they are to other Democrats. And there are Republicans that are closer to some Democrats than they are to other Republicans. Roll forward through, so it looks like kind of a mixed blob, even though there clearly are parties. Roll forward to 2011, and you can see that we are now bimodal. We're two different camps with no one in the middle. And actually, those few dots that you see in the middle, they're basically gone now. So if I updated this to 2015, they'd be gone too. So it's completely two different camps. So then the question becomes, what's driving this and what are the consequences? The first thing that every talking head on CNN will say that's driving this is gerrymandering. We are carving up political districts into things that look like pieces of spaghetti, and that's what's causing this. So I am not a professional political scientist, but I thought an easy way of trying to test that proposition would be this kind of graph, where you look at the House and the Senate and measure polarization in both bodies, because at least to my knowledge, we have not redrawn state lines. So it's interesting that the Senate has polarized almost as much as the House. And indeed, what the kind of professional political science literature finds is that gerrymandering can only explain something like 10 to 20% of the rise in polarization in the House. And then political scientists you thought economists were nasty? They get in heated fights. So then the fight becomes, it's not that, so they can all complain about CNN and media coverage. But the big debate is this happening just because the elites are polarizing, or is the population polarizing? And since I'm at Stanford, I should say the Stanford view, embodied in Morris Ferrione's work and others, is that it's mostly the elites and that the population is not polarizing. I'm increasingly of the view that it's not entirely clear to me that that's right, and that that polarization is happening at the popular level also. So let me show you one example of that. This is an example of residential segregation in the US by political party. So this is whether your county voted by more than 20 percentage points in your direction. You're either going to be black or gray. So that's a polarized county. That's what the United States looked like in 1976. This is what it looked like in 2012. And I would put to you that in 2016, it's going to be even worse. And actually, this ties into the gerrymandering point, because it doesn't matter how you draw congressional districts around those counties, you're going to wind up with a heavily polarized district. To the extent that this is driven in part by self-selection and self-sorting, one of the strongest findings from social psychology is put like-minded people together in a group, the group will become more extreme than any individual within it. To the extent that that's what's happening, this is here to stay for some period of time. And then that brings me to, okay, how do we function in that kind of setting? And I think the short answer is, again, the only way that you get big legislation, given these kinds of facts, is if one party or the other wins the trifecta, the White House, the House, and the Senate. The House is going to remain Republican for the foreseeable future, so the only trifecta that's possible is a Republican one. This may help explain why I'm no longer in government. Now, in order for the Republicans to win the trifecta, they not only have to win the presidency, they have to retain the Senate, which is not as easy as it might seem, because there are 24 Republican seats up, only 10 Democratic seats up, and the Senate may well flip. But let's take a hypothesis where we explore the consequences of that trifecta: Republican House, Senate, and White House. And I'm now a member of the White House transition team, which Professor Boskin will tell me will never happen. I would never be a member of a Republican transition team, which is correct. What would be prioritized? Where would they actually go with this shining moment of political domination? And all of the rhetoric is about repealing the ACA. I would put to you, I think that's very unlikely to be where a new administration actually puts down its markers during the first 6 months. The problem with doing that is it causes immediate harm to people, and that's easy to say, repeal the ACA, but when you're taking away benefits that people already have, very hard to do. So I would instead suggest, if I were advising a Republican transition team in this setting, that I think what the two things that are the most likely to happen is the first is block granting Medicaid. Medicaid is currently a split federal-state program. Turning it entirely over to the states while providing federal funding, similar to what we did in welfare reform in the 1990s, checks so many boxes. First, no immediate harm to anyone. If anything bad happens, it's the governor's fault, not mine. Second, consistent with Republican rhetoric around fiscal federalism. Third, you can pretend that it dramatically reduces the deficit because actually a surprising share of the deficit reduction in Paul Ryan's budget comes from block granting Medicaid and then flatlining the block grant, having it rise only with inflation, not with healthcare costs. So over time, magic. And the fact that governors in 30 years might have a problem, not my problem. It looks good on paper. And finally, you might even be able to dress it up as some form of ACA repeal or reform, given that there was a big part of the ACA that was delivered through Medicaid. So it checks multiple boxes. The second thing I think that might happen is currently we have 30% or so of Medicare beneficiaries enrolled in private insurance plans through Medicare Advantage. This is one of the biggest prediction errors that CBO and others made following the Affordable Care Act. Medicare Advantage was projected to plummet following the cutbacks that were embodied in the law. Instead, it's skyrocketed. And I would suggest to you that at 30% penetration rates, Medicare Advantage is here to stay. In a Republican trifecta, it may be more than here to stay and get an additional push through what's called premium support, which is just one form of providing additional support to the program. But I know that I'm running short on time, so I'm going to quickly turn to the final topic, and then I'm skipping all this great stuff, which we can come back to. Just very briefly, maybe this is the way to do it because it will immediately interest the 50-year-olds in the room. We have seen a dramatic change in the pattern of life expectancy in the United States, and this is from the National Academy of Sciences panel that I mentioned. So if you look at, you've made it to age 50, and what's the probability that you'll make it to age 85? If you were born in 1930 and you were in the bottom 20% of lifetime earners, the probability that you would make it to age 85, having made it to 50, was about a quarter. If you were born in 1960, it was about the same. Look at the top 20% of earners, though. Born in 1930, probability less than half. Born in 1960, 2/3. That increasing gap is showing up in Social Security, Medicare, Medicaid, and other programs because as higher, better educated people increasingly live longer than everyone else, they get their Social Security and Medicare benefits over a longer period of time. And so the net effect is to make those programs less progressive over time, whatever their initial level of progressivity was. So I know I'm out of time, but I just wanted to at least flag that you've heard a lot about income inequality in the United States. I strongly suspect that we will be hearing much more about life expectancy inequality in the United States, including what's driving it and what the fiscal and other consequences might be. Thank you very much.
Okay, great. Well, thanks, Peter. That was really fascinating. I'll just give you a question, and then we'll open it up for everyone else. So one of the things that you put on your slides showed how Medicare and Medicaid spending was growing much more slowly than CBO had projected 5 years ago. And some non-trivial share of that is attributable to states like Texas and Florida deciding not to expand their Medicaid programs. Now, if you look today at the most recent data, this is publicly available, very easy to see. In Texas, 1 in 6 state residents are now on the Medicaid program. Texas is actually a slightly lower income state than California. In California, it is now 1 in 3. So 1 in 3 Californians are on Medicaid, Medi-Cal here in California. So if you talked about this idea about block grants and so forth, do you expect that the sort of political dynamics that you talked about as we run through 2016 to lead more of the 20 states that have decided not to expand Medicaid to try to do so. Because right now there's just a dramatic difference between states like California and New York and states like Florida and Texas. And that's the big difference.
Right. Well, so I think the details of how you do a block grant are actually really complicated. It would not be surprising to me if there were a different approach for the expansion part of Medicaid, which is what you're discussing, and the base part. There's also hard questions about the people who are dually eligible for both Medicare and Medicaid and how they would be treated, because you'd effectively probably want to shift them onto one program or the other. So it's easy to say block grant. It's actually really hard to do, and I don't know exactly how it would play out. I don't think that this possibility, though, between now and then is going to cause Texas to decide that it wants to become a Medicaid expansion state. Let me put it that way.
Okay, so let me ask one more question before. I said I would do just one, but I can't resist. So you didn't talk much about the Cadillac tax.
I had slides on it.
Yeah, I know. I was giving you a little extra time.
Okay.
I said, I would put it up to 5 before, 30 seconds before you finished. So the excise tax, the Cadillac tax, is set to kick in 2018. Maybe you can describe to people a bit what that is, and how you expect that issue to sort of whether it will matter much in the 2016, both as we go through the sort of early 2016, the primaries, but also the general election.
So first, just a little bit of context for the people who are not as attuned or don't follow the economics literature on healthcare as closely. It has long been the case that economists believe that not the only, but one of the drivers of excessive costs in the US system is the tax preference that's provided through employer-sponsored insurance. So your healthcare benefit is not taxed, wages are. That makes generous healthcare benefits look a little bit better, and then that drives up spending, including costs for everyone else, because we wind up with really high utilization patterns. The Cadillac tax was a very imperfect way of trying to get at some of those issues, and what it entails is an excise tax, a 40% tax, which is a quite steep tax, on healthcare, employer-sponsored and other healthcare that is above certain thresholds, depending on whether you're in single coverage or family coverage, taking effect in 2018. It is already starting to affect employer behavior because no one wants to come in above what the thresholds are. The goal, and this has often been kind of miscast, the goal was precisely to make employer-sponsored insurance more efficient and more value-oriented. And in fact, 2/3 of the revenue that's assumed to be generated by the Cadillac tax is not from collecting the Cadillac tax. It's because it's assumed that employers will respond, change the form of their compensation away from tax-preferred health benefits and towards other taxable compensation, and the result of that will be higher taxes or higher revenue. So where are we? This is one of these interesting rainbow coalitions where you have a lot of Democrats in favor of repealing this tax, mostly because the unions are very vociferously against it. And then you have pretty much every Republican in favor of repealing the tax because it's part of the ACA. So you have this odd political configuration where Bernie Sanders and the entire Republican Party agrees on one thing. So what is likely to happen? A lot of people who haven't spent as much time in Washington will say, well, that means it's dead and it's about to be repealed. I'm not so sure. That might happen, but I'm not so sure that that's the case. Don't forget, just being purely Machiavellian and again playing Republican political strategist, which is an odd thing for me to be playing. If you can split the other party and there's no immediate consequence to delaying the pain, that's a good thing from your narrow political perspective. This splits the Democratic Party. This is something that Hillary Clinton and Barack Obama are on different sides of, and it doesn't take effect till 2018. So the need to repeal it in 2016 might not seem as urgent to politicians as it might to business leaders who are saying, but I need to know now because I'm designing my plan now. So if you ask me what is likely to happen, I would bet nothing until early 2017 with a new administration. And at that point, given the complexity of a lot of the changes, it may well happen that what the most likely outcome is just to defer the implementation for a year or two, like we did with the doc fix repeatedly. So we just keep pushing out, it's not 2018, it'll take effect in 2020. Might not be the best outcome, but if your goal is to try to change corporate behavior, you don't actually need the tax to take effect. You need the threat of the tax. And so as long as the tax is hanging out there and it's even partially credible that it might take effect, you might get a lot of those benefits.
Interesting. Okay, great. Well, I'm going to open it up now for questions from the audience. So if you have a question for Peter, let's start right here in the front.
You know, most of the business owners that I know don't want to pay high insurance premiums. It's very competitive. And I think there's some assumptions in this about the government trying to create behavior rather than the free market creating behavior. And also, with a lot of the data you put up there, it's so complicated you can't connect and come to conclusions that I think you've come to, that you just don't have enough data. It's too broad.
Was that a question? So I guess there are a couple pieces to this. One is, should anyone claim that we know for sure what's going to happen to healthcare utilization 5 years, 10 years from now? No, and I hope I wasn't trying to claim that. Do we know what happened over the past 5 years? I think fairly well, actually. So despite a lot of the hoopla around it, the fact of the matter is, I mean, let's focus on Medicare, for example. Medicare in fiscal year 2014, on a inflation-adjusted per-person basis, which I think is the right way of doing it, spending actually fell. If I had stood up when I was in office in 2010 and said, I have a thought, I think in 2014, real person spending in Medicare will decline, I would have been laughed at. So there's a puzzle here of why that's happened when we know it's not the economy, and we know it's not mostly prices, it's utilization. So why has utilization fallen so much in Medicare? I don't claim to know all the answers, but that fact that utilization per person declined, I'm pretty confident of that. Other parts, less confident. So it varies depending on which part of the presentation you were complaining about.
Okay, next question. Professor Boskin. Oh, sorry, yeah.
Two quick questions. Have you looked at those numbers broken down by narrow age cohorts of the retired population? Because the young old are growing rapidly with the baby boom retiring. I mean, part may be the mix by age. And the other question is, just first a perspective, one reason a lot of Republicans didn't like the Medicaid expansion was that the governors thought that the money wouldn't be coming after a few years. They'd be stuck with a much bigger bill. But also they had struggled to get any waivers to do experiments in Medicaid. Governor Brown wanted to put in a $5 copay in Medicaid, and your former boss rejected it. So they felt that it was becoming increasingly unflexible. And so the question is, do you foresee, if it's block granted, that there would be a lot of reform in what states are allowed to do?
So on the first question, if you do you're absolutely right. So as the baby boomers age into Medicare, you have more 65-year-olds and, as a share, a lower weight on 85-year-olds, and that would drive down real per-person spending. It looks like if you do the demographic adjustment, which CBO has done, that's about 10% of the deceleration since 2010. So most of it's not price, and most of it is even after you demographically adjust. But it's clearly there, and I don't want to diminish it. With regard to Medicaid waivers, so I guess the first thing is a block grant only happens if it's associated with kind of hands-off in terms of operational flexibility. The two ways in which you make a block grant attractive to Democratic governors are, which they would sort of be somewhat skeptical of, I think, just by nature. One is that the operational flexibility is you'll be able to run your program the way you see fit, much more so. And the second is you can bump up the block grant payments for some short period of time and then flatline. That's actually what we did in welfare reform too. And it's almost irresistible with a little bit of extra money on the table to resist that kind of block grant. I guess the only final thing I'd say is I do think the pattern has changed a bit, and we are seeing much more openness to a whole variety of Medicaid waivers. Most importantly, through what's called the DSRIP, through a variety of programs, but one of them is the DSRIP program, Delivery System Reform Improvement, something or other, that is taking lots of state programs. I'm most familiar with the one in New York, and moving Medicaid to being more value-based, which I think is exactly what we should be doing directionally, and it requires waivers, and we're seeing more of them. The Arkansas waivers with regard to the exchange is another example. So I'm not disagreeing with the perception that was the case at some point, but I also think the administration in its last few years in office, realizing you're not going to really get new legislation, might be more open to waivers as a form of moving the system over the next 12 months.
Okay. Next question. How about in back?
I wanted to follow up on your question about bundle payment and accountable care organizations. And I'm trained as a physician, and I worked for a number of years in Kaiser Permanente and for a number of years in the community-based fee-for-service delivery system. Kaiser Permanente depends upon a sense of teamness. We're all in this together, the hospitals, the doctors, even perhaps the rehabs. Fee-for-service does not. Accountable care organizations, in order to be one, you have to kind of negotiate those team arrangements. Bundled payment, here's the money, guys, go for it. And you have, rather than a teamness of the physicians, hospitals, and rehabs, you have competition over who gets the biggest bite. How is it going to be possible to impose a sense of collaboration and teamness on the delivery system through bundled payment, rather than allowing the system to develop its own team collaboration through accountable care?
So that's interesting, because I wouldn't have said that that's a important distinction or source of variation between bundled payments and ACOs. Whoever's on point for the bundled payment has a strong incentive to build that network of teamwork. So if I'm getting a fixed payment for a hip or knee surgery, and I have to worry about all the post-operative, all the post-acute, et cetera, I want to build that team, and it's coming out of my pocket. So just like with an ACO, I have an incentive to build a collaborative team around that. I think instead the trade-offs are more in the form of the following. The benefit of a bundle is you know when it starts, because someone's admitted to the hospital for a particular episode, at least if we're dealing with acute care episodes. The difficulty with the bundle is, when does it end? What are the boundaries? Is it 30 days after discharge? Does it include, what if they entered for this and then they wound up getting a hospital-acquired infection and it went off this way? Is that included? What are the contours? With an accountable care organization, it's clear you're responsible for everything. On the other hand, the problem with an accountable care organization is the attribution rules are very hard. How do I know that's my patient? And right now, that's one of the biggest messes in accountable care organizations, which is hospitals will often find out who they're responsible for after the fact. That's not a great way of dealing with incentives and what have you. And there's also then the question of how much risk you're bearing. So under an accountable care organization, again, the hospital or whoever the provider group is that's bearing the risk has to get into the business of figuring out how many heart attacks are there going to be in this population, how many, this, that, and the other thing, which is the old school insurance company role. And one of the reasons why we're seeing such rapid growth in valuations on the firms that provide those kind of analytical services to providers is precisely that they're bearing some of this risk, but they don't really know what they're doing with it, and they need help. There's also a legitimate risk. This is not true in California, if I remember, but depending on the state, you can wind up effectively having all of the insurance risk, that is how much utilization there is, without the kinds of reserves that insurance companies typically have to hold. So it doesn't matter who underwrites the lives, which is where most of the regulations are. It's ultimately who's bearing the risk. So if the insurance company underwrites a life and then transfers all the risk to a provider, I'd say the risk is residing with the provider, and there's some possibility a bunch of hospital systems will blow themselves up financially by taking on way too much risk without either the analytical experience that insurance companies traditionally have had or the financial reserves that they typically have. And I think that's a legitimate, significant concern for ACOs. And a related point to your team effect is think about what a hospital has to do as an ACO. So traditionally, something like 30% of the care that an accountable care organization or hospital would be responsible occurs outside of the four walls of that organization. So they have to build out-of-network relationships, not just with the preferred providers, but with what if the person happens to wind up being in Florida and needs help? How does that get handled? The final thing I'd say is all of this, whether it's bundled payment, but especially accountable care organizations, may have fundamental effects on the pharma and device sectors in particular over time. Imagine a world in which we're fully to capitated risk, or ACOs, for providers. Then whether I'm going to pay for this new device or how much I'm going to pay, or this new drug, depends a little bit less on whether you succeed in getting Medicare to cover it, or whether you succeed in getting the following four big insurance companies to cover it, and much more on whether the medical director at Hospital X thinks this thing is worth it, given that it's going to come out of their bottom line. That's a much different model for how innovation, the incentives for innovation and how it gets financed than our current system.
Great. Okay, another question right here. Mr. Morgenthaler.
You indicated you would take broader questions.
Sure.
And so my first part of my question would be, what legislative action is your best guess as to what will be done to contain the cost of health care in the future? And specifically, what do you look to as reduction of the cost of end-of-life care?
So there are a few, first of all, honestly, I don't expect any big legislation over the next couple of years, certainly not over the next year. And in 2017, to the polarization point, unless you have a trifecta, which would have to be a Republican trifecta given the House, I also don't expect big legislation. With regard to end-of-life care, there are, though, however, a few things that are worth noting. The first is, while it remains a very important topic, the share of spending that is in the last 6 months of life has declined relative to historical estimates. So traditionally, people would say 25 or 30%. The share is now down to something like 17%. It's still big, but it's smaller than it was historically. So that's the first thing. The second thing is we have now moved to reimbursing doctors for having end-of-life discussions. It doesn't determine what the outcome of that is, but it does suggest that having a discussion will not just be benevolence from the doctor. They'll actually get compensated for that, which I think is a good thing. It's fascinating to me on this debate because anything involving end-of-life care, which if you think about the voluntary decisions, I want X or Y, is really the ultimate consumer-driven healthcare. I mean, you are saying, I want X or Y. It's the ultimate consumer-driven healthcare. It is anathema to the biggest proponents of consumer-driven healthcare because somehow we should be, deciding which lab tests we should be getting, but not what our end-of-life care looks like. The evidence also suggests that if you do force people to decide through living wills or advanced directives or what have you, not everyone, but a significant share of people, a third or so, will decide that they want the lower cost alternative of being able to go home, be with their family members, and not have everything done to them at the end of life. It strikes me that at some point we may face very challenging problems about what to do with very high end-of-life costs, but the very first step that we should be doing is asking people to determine their own futures more definitively. It's not perfect, because you can often get into ambiguities, well, I didn't mean that, or a family member says that wasn't really the case. But I think it's a start, and we're still doing so little of it that there's massive potential for improvement there. Doubt very much that's going to be legislation, because it's such an explosive topic. But this, frankly, can be done through healthcare providers. There are hospitals, Gunderson Lutheran Hospital in Wisconsin, for example, requires an advance directive for admission to the hospital. You could just do that as a provider.
Okay, one more question, right here.
Given the dramatic data that you presented for the conditional life expectancy, what do you see the policy implications of this, particularly with regard to retirement age on one side and the cap on payroll tax?
So I'd say the first thing is any argument that is of the following form: life expectancy has gone up by X, therefore the normal retirement age under Social Security should go up by Y, really needs to pause and think, given this dramatically different life expectancy trends by socioeconomic status. Average is over for life expectancy, basically. And so anything that's based on that argument probably needs to be reconsidered, and approaches that reflect this disparate trend in life expectancy could include a whole variety of things. One argument, for example, is we should make the annual Social Security benefit more progressive to offset the fact that higher earners are increasingly living longer, so they're getting more lifetime benefits. Now, normatively, you could agree or disagree with that, but that would be one possible way you could go. There are lots of other different ways. You can also raise the maximum taxable earnings cap in part to offset the progressivity impact of what's been happening, absolutely. There are lots of different approaches. I guess the only point that we tried to make, National Academy of Sciences doesn't make policy recommendations, so there were none in that, other than to just say it's not a policy recommendation, but in doing the policy analysis, you should take into account these differential trends in life expectancy. As simple as that.
Okay, great. Let's wrap it up there. Thanks so much. Orszag.